Which brings us on to propensity scores and how I think they can help us to avoid this problem. So we'll talk about the theory, approaches to using them, and we'll use a practical example to take us through how this works. So the theory is that the propensity score itself is simply the probability that an individual would receive a drug based on the observed distribution of risk factors for receiving the drug. And I'll talk you through an example so you can see intuitively how this works. Well, we start by thinking about what are the factors that might influence the decision to prescribe a drug for a patient. And we use that to calculate a probability for each person. Now, ultimately, the research question that we will be interested in is going to be something to do with an exposure. Let's say it's a statin, because in the example it is, and the unexposed people are going to be people not taking a statin. And ultimately, we may be interested in some outcome after taking a statin. So that's what we're really, really interested in. But to use a propensity score, we start off by ignoring this bit, and instead we look back in the patient's medical history and we look for the association between having the exposure and various things in your medical history. So effectively, we treat the exposure itself, so receiving the statin, as an outcome, and we look at what are the risk factors for receiving that exposure. Does that make sense? So it's a little bit like a case control study. So this is the starting point for using propensity scores, that we start just with the exposure and look at the risk factors. So we think of all the risk factors we can, and we put them into a statistical model as exposures that may have led to the outcome, which is receiving a statin. We simply run a logistic regression model with all of those variables in it, and after running that regression model, we then run a simple command in the software that calculates a probability for each patient in the group that says, based on their risk factors, what was the probability that they would be prescribed a statin. It doesn't actually matter at that point whether the patient did receive a statin. The probability will be a true probability if we've got a good model. So in other words, every patient within the data set who has a propensity score or a probability of 0.2 will have had a 20% chance of being prescribed a statin. Some of them will have genuinely got a statin, and some of them won't. That's just how the way it works. So if you had a 20% chance, that would mean it was quite a low chance. Maybe you just have a 20% chance because you're aged 65 and you're a male, but you don't have any other major risk factors for receiving a statin. Now, if you think intuitively, if you were to take 65-year-old males with no other risk factors, some of them would be on a statin, not that many. Most of them would not be on a statin. So intuitively, that makes sense, I think, yeah. So you've got this position where some of the people with a score will be taking the drug, some of the people with the same score will not be taking the drug. And we're going to make use of that within our analysis. So the research question that we were interested in a few years ago was whether or not people taking a statin were protected against mortality after having pneumonia. Okay, so we weren't interested in whether starting a statin when you've got pneumonia was protective, purely whether if you were on a statin when you got pneumonia, whether that was protective. And we did this within a database in the UK called the Health Improvement Network. It's very similar to the CPRD. It's based on many of the same GP practices. And the eligible patients were in the database between 1995 and 2006 and aged over 40 years. The design we used was a cohort, and we started off by selecting all of the statin users who were eligible within the database. We matched each of them to a non-user, so somebody not taking a statin, on age, sex, being at the same general practice, and being present in the database at the same time that the other person got their statin. We then calculated a propensity score for receiving a statin based on a whole range of variables, which I'll show you in a minute, a range of variables which we thought may influence a doctor's decision to prescribe a statin. And this was using conditional logistic regression with statin status as the outcome, so yes or no, and the covariates as the exposures. So we started off by thinking, what might influence a decision to prescribe a statin? So high lipids, so statins lower lipids and then hopefully reduce the risk of a heart attack. So you would hope that high lipids should be quite influential in a decision to prescribe a statin. Yeah? So here's the data, and I've broken it down by, in the columns you've got statin users and non-users, and then in the rows you can see people who've got hyperlipidemia and people who've got no hyperlipidemia. Now, not surprisingly, amongst people who've got hyperlipidemia, 30%, amongst statin users, 30% have high lipids. Yeah? Amongst non-users, only 3% have high lipids. So that's intuitively makes sense, yeah? That's how we would expect the data to look. If we imagined that having high lipids was the only factor in the world that influenced whether or not you got a statin, then we could then very simply calculate the probability of being prescribed a statin if you have high lipids. Yeah? If you imagine nothing else influences that decision, just having high lipids. So it would be this very simple probability equation here. What's the probability of receiving a statin given that you have high lipids? And so it's literally, in our study population, if we take everybody with high lipids, it's the number of people with high lipids who are receiving a statin divided by the total number of people with high lipids. And it would be 0.7. This would then be the propensity score for everybody with high lipids. So that includes the people who are not prescribed a statin, okay? This is really, really important point to get, that everybody with high lipids would have a propensity score of 0.7. Some of them will have got a statin, some of them won't have got a statin, okay? But that would be the score for everybody with high lipids. We would then calculate at the same time, what's the probability of being prescribed a statin if you don't have high lipids? Because this is everybody else in the data set, yeah? And it turns out that we would do the same thing. We would calculate what's the probability of receiving a statin given that you've got normal lipids, and it would be the number of people, so the total number of people who have got normal lipids would be the denominator, and the numerator would then be the total number of people with a statin and normal lipids. This would give us a number of 0.13. So it would mean that everybody in the whole data set, regardless of whether they're taking a statin or not, would have had a probability of taking a statin of 0.13. Yeah, everybody with me? Great. So that would be in the strange world where only having high lipids influences the chance of taking a statin. Of course, that's not the case, and there are other things that would influence the risk of being prescribed a statin. So the second one, you may imagine, would influence the chance of having a statin is a history of coronary heart disease. So again, we would hope that people who've got this history might be prescribed a statin. So here we've got, I've broken the data down into 4 strata. So starting off with people who've got both high lipids and coronary heart disease, and then people who've just got high lipids but no coronary heart disease and normal lipids, and then neither high lipids nor coronary heart disease. So kind of graded from the sicker people down to the more healthy people down here. Okay? So these are what the data look like, and the propensity score is then simply a read across of, from these strata, what's the proportion of people who are treated with a statin. So 83% of people in this group are treated with a statin. It means that the propensity score for everybody in the data set who's got high lipids and coronary heart disease is 0.83. Yeah? Conversely, amongst people who've got neither high lipids nor coronary heart disease, the propensity score will be 0.09. There may still be some people in this group who do get a statin, but their propensity score is still 0.09. Okay? So of course, we think that there are probably lots of factors that influence that prescribing decision. And in fact, in our final model, we had about 30 different variables that we thought could influence this decision. So we've got things like whether or not people smoke, whether they've got diabetes, atrial fibrillation, whether they're using a whole range of other medications. There's just a whole load of different things that we thought could influence that decision. Yeah.
Do you mind going back to the slide? I noticed you have socioeconomic status. That's very qualitative. How do you kind of quantify it? Just wondering.
Good question. So, depending on your setting, so in the UK, we have access to individual patient postcode level. So, a postcode would typically include, let's say, 30 houses. So, it's a small local area. And we've got broken down into 5 strata of things like income level. And so it's like a scale of relative poverty. And so we would have it on a 5 stratum level. Which of those strata are you in your postcode?